get started again. But welcome everyone to the Mayor's Town Hall, Franklin Township. We have the mayor and we have a guest speaking on COVID-19 boosters, and we will follow our standard format where we'll hear from the mayor and his guest, and we'll take questions from local press, and then we'll take questions from Facebook. So getting started, I just wanted to introduce Dr. Ronald Nahass, who joined us, I think, at our last town hall, or a recent one certainly, and graciously agreed to come back. He is local and has an office here on Veronica Avenue in Franklin, as well as other locations, and as part of ID Care, which is the largest infectious disease prevention and treatment organization in New Jersey, and is an infectious disease expert. So we welcome him and welcome Mr. Mayor, and take it away, sir.
Thank you. And thank you, Dr. Nahass, for donating your time to this. He's also been on the Somerset County Task Force. And while many of the citizens of Franklin consider me an expert because I'm a doctor, my knowledge pales in comparison to his. His specialty is infectious disease, and certainly he knows he lives the details every day of this. So how are you doing tonight, Dr. Nahass?
Very well, thank you, Mr. Mayor. Appreciate the opportunity and happy to be here.
Great. So I've got a few questions. Before we get to boosters, which is on everybody's mind, the standard shot, the first shots you get, who can get what now?
Well, anybody that at this particular point, anyone who's not received a standard dose is certainly eligible, encouraged, and really I would personally encourage them to get their standard shots. So if you've not gotten the vaccine, you've delayed for whatever reason, no time like the present, please go out and get your shots. So they are available for anyone who's not gotten any of the shots. And basically, probably by next week, the first shots will also be available for children. You may have some specific young children, specific questions for that. But at the moment, anybody from the age of 12 and up who's not yet received what I would call the primary doses of the vaccine are eligible and encouraged to go ahead and get them.
And they can get Pfizer now?
They can get Pfizer. Well, 12 and above can get Pfizer or Moderna or J&J, and all of those, anybody can get those initial doses, and we're encouraging anybody to get a shot. Want you all to get vaccinated.
Who is eligible for the booster?
So at this particular point, the FDA and the CDC have both weighed in on the boosters. And as I like to say, really essentially almost everyone. I think correctly, the initial groups that were encouraged to have, and it gets a little bit semantic here, third dose or booster, were what we would call the immunocompromised hosts. So individuals who might be at risk of not having an adequate response to the vaccine, someone who's at a transplant, for example, let's say had a kidney transplant, or someone who might have a leukemia of some type. Those individuals would be considered immunocompromised. And initially we were encouraging those individuals to get a third dose, was the term that was used, to encourage their immune system to respond better. Subsequently, and in the last 2 weeks or so, the CDC, the FDA have come out and broadly endorsed a third dose or a booster for essentially anyone. And I say essentially anyone that because I think it gets confusing. If you actually look at the criteria that the CDC stated, you would see, 4 or 5 groups of individuals, 65 and older, immunocompromised, anybody who works or has a job in a high-risk situation or lives in a high-risk situation. So my answer to that, and the way that I help people understand this, is we are still all living in a high-risk situation. We have a state that, by the way we evaluate risk, is still orange. We're not red, thank God. Red's garnet is the worst. Red is next. Orange, yellow, green. We're not green. We're not yellow. We're orange. So our state is still considered a high-risk state. And so therefore, as per the guidance, anyone that lives or works in a high-risk situation is eligible for a booster. Everyone in New Jersey who's had 2 doses of Moderna or Pfizer, or has had 1 dose of J&J, lives in a high-risk situation, go get a booster.
Okay, great. So what booster do I get? Say I got Pfizer, what do I get? Say I have Moderna, what do I get? I had Johnson & Johnson, what do I get?
Well, I think we can make 2 distinctions here, and I do think it's important. It's a very important question. The J&J vaccine is what we call a viral vector vaccine. Moderna and Pfizer are what we call mRNA vaccines. If you've had the J&J vaccine as your initial vaccine, you got 1 dose. If you've got the Moderna or the Pfizer vaccines as your initial vaccine, you got 2 doses. If you've got the Moderna or the Pfizer vaccine, it actually doesn't matter. Get almost any dose you can get of whatever is available to you. A Moderna shot, a Pfizer shot following a Pfizer or Moderna, it doesn't matter. We call that, people in the news, everybody likes to talk about the mix and match concept. If you've had an mRNA vaccine, you can mix. It doesn't matter. Get whatever you can get. If you've had a J&J vaccine, I think it requires a bit more thought for a couple of reasons. One is it's pretty clear that the immunity from that vaccine wears off more rapidly, probably because you only got 1 dose. So you can get actually your booster dose for J&J at 2 months. For the Moderna or the Pfizer, it's 6 months. Number 2, if you've had the J&J vaccine, the information that's being accumulated appears to suggest that the booster should be with an mRNA vaccine, because the immunity you get if you had the J&J single dose by getting the booster with an mRNA dose, Moderna or Pfizer, that immunity is much, much better. So generally, I'm advising people who've had J&J to get an mRNA vaccine as their second shot. If you've had Moderna or Pfizer, it actually doesn't matter. Get whatever you can get.
Okay. There's been some bit of a scare about J&J. Are there particular people who shouldn't get a J&J vaccine?
Yeah, the J&J vaccine, there's been some concerns raised about a blood clotting disorder. So as a rule, we're suggesting that individuals, particularly women, between the ages of 18 and 50, that's the age group. Those are the groups that that's the group that seems to be at risk for the clotting disorder. I generally would tell women in that age group not to get J&J vaccine. So that group should avoid that vaccine. The risk, you would know, of Guillain-Barré seems to be a little bit higher with the J&J vaccine. So if there's some concern about that as a consequence, you might want to avoid the J&J vaccine. But outside those 2 particular groups, it otherwise doesn't seem to matter whether you get the J&J or not. On the contrary, the mRNA vaccines appear to have a greater risk of this heart inflammation side effect. The term for that is myocarditis. If you're a young man, probably up until the age of about 30 or 35. So if you were sort of playing the odds, you might say, well, maybe I'll get the booster if I'm a man and I'm 30, I'll get it with the J&J. But we are, I guess I gotta say, Mayor, regardless of whether you're looking at the risks of the blood clotting disorder or the risk of myocarditis, both of those risks are exceedingly low regardless. And the vaccine safety profile, now that we've given hundreds of millions of people these vaccines, really continues to be amazingly impressive, particularly when it's measured against the risks of COVID. So I think in general, you can be reassured the vaccines are safe. The caveats are what we said relative to the blood clot and the myocarditis.
Yeah, as far as the blood clot goes, I think 3 people total have died from J&J. And that was from a cerebral blood clot. And so if you do get J&J, especially if you're a woman between 18 and 50, and you get a severe headache, usually somewhere between 10 days and 19 days out from the shot, you should go to the hospital, tell them you have a bad headache and you got a J&J, and they will know what to do. It's the people who died, they didn't know what to do. It was, it was a new thing and they didn't know how to handle it. I've never made that diagnosis. It is it is kind of a hard diagnosis to make when someone has a headache, that's the cause. So if you tell them you got a J&J, they'll know exactly what to do. All right, here, this is more of an ethical question than a medical question, but some people have said, in the United States, we're talking about getting a 3rd shot while there's countries where people haven't gotten any shots. What are your feelings about that?
And this has been an ongoing discussion, even with the deployment of the vaccine in the young folks, because some have argued that maybe we shouldn't be giving the vaccine to our children or people in their teens or even younger now with the new impending approval, because the consequence of the disease in that age group is much less impactful than in people who are older, particularly when we haven't deployed the vaccine across the globe more broadly. So the equity question has been there all along, and we now add a new twist to it. And that new twist is we're deploying a booster dose when, again, the vaccine hasn't been widely distributed across the globe. There are a couple of thoughts relative to that. One, the United States certainly is not alone in deploying a 3rd dose or a booster dose. Israel actually is leading the world in that. They have well over 40% now who have actually gotten their 3rd dose. And there are a number of other countries across the globe that are, in the 30 or 40% range for 3rd doses. So certainly other countries, including the UK and a number of the European countries, are deploying 3rd doses. So this is certainly not without precedent. The second thing is that there has been an extraordinary effort to contribute and deploy vaccine worldwide. The numbers of vaccines that have been made available across the globe are really quite extraordinary. An awful lot of that, though, is actually being thrown out, which is almost tragic, because part of the challenge that we've not mastered globally is the logistics of delivering and deploying the vaccine. Maybe you can ship it, but if you can't get it from the airport out into the field or into the village or into the community in which it's needed, and you end up throwing out doses, that also is pretty tragic. And so we have a lot of different issues as we think about how to effectively deploy the vaccine on a global scale. And I guess my general thought has been, let's get the people that we can vaccinated so that we're creating fire breaks across the globe that continues to help slow the spread of the virus. Because the overall concept, and I know you have some other questions about this, but the overall concept is herd immunity. And the concept of herd immunity is get as many people as we can vaccinated, because there will be people that we can't vaccinate or that will not respond to the vaccine. And so by creating a ring of protection, we make it that much harder for the virus to disseminate across the globe. So yes, let's keep working real hard at deploying the vaccine worldwide. There is a lot of capacity to make vaccine, and lots of countries are supporting that. We need to work on a global scale, the logistics of getting the vaccine to where it's needed. But at the same time, let's deploy the vaccine as we're beginning to recognize most effectively to create more and more fire breaks, to really prevent yet another surge of this virus, whether it's in this country, in this state, or worldwide. And I think deploying 3rd doses is helping us do that.
Thank you. So you led into my next question, when you mentioned herd immunity, according to the state website today, Franklin, 79% of people have gotten of all ages have gotten the first dose. 71% have gotten the second dose, or with Johnson & Johnson at least have completed the dose. Now you have to be careful of that number. Of those who've gotten the first dose over age 65, 108% have. So I think the denominators having a little bit of trouble with the denominator.
Right.
But anyway, so why aren't we at herd immunity now?
Yeah, that's a moving target. When we started this, I remember all too well, unfortunately, in March and April of 2020, when we were first dealing with that god-awful surge that we all dealt with here in New Jersey. And we were watching what we call now the ancestral strain of the SARS-CoV-2 virus, or the COVID disease. We thought that herd immunity for that particular variant, the ancestral variant, was somewhere around 75, 80%. And that's a number, that's actually a number that can be calculated based on what we call the R0. R0 is the transmission, the effectiveness of the transmission of the virus. And at that time, the R0 of the ancestral strain was considered somewhere around 2 to 3. Now that's moderately transmissible. Seasonal influenza, for example, has a transmission rate, or an R0 of around 1 to 2-ish. Compared to measles, which is highly contagious and has an R0, it's the most contagious virus known to man. The R0 of that virus is 15. Herd immunity for measles, and we know this in this country, is actually over 90%. If you don't have over 90% of your population immune to measles, measles can establish itself in a community. And the United States has had small outbreaks because we have communities within the United States that actually don't achieve 90% immunity. Some of you maybe recall the outbreak we had in California about 3 years ago. And that was because the immunity status in that community was under 90%. Now, what's happened with COVID over the last 18, 20 months is the virus has mutated. And it's mutated in a significant way twice. The first mutation was this past winter. Our winter wave was predominantly caused by what we now know as the Alpha variant. The Alpha variant, originally known as the UK variant. And that variant caused our winter wave and was slightly more transmissible than the ancestral variant, the original one from the start of the epidemic in March of 2020. The R0 for that variant was somewhere around 3 to 4. Remember, I said the ancestral variant had an R0 of around 2 to 3. The Alpha variant was 3 to 4. Then what happened this spring? This spring, it was all about, and still is all about, the Delta variant. The Delta variant started, or was first recognized, I shouldn't say started, but was first recognized predominantly in India. It caused that awful wave in India in the spring. And it got, it became worldwide and began impacting the US and New Jersey in particular this past summer. And so we all are still dealing with the Delta wave, and the Delta variant has an R0 of about 8 to 9. So we've moved from 2 to 3 to 3 to 4 to 8 to 9. Remember, I said measles is 15. Measles is 15. Chickenpox is about 8 to 9. And so you can do the calculation if you were so inclined. I can't, I got to look it up. But the calculation tells you that with a variant or a virus that has a R0 of somewhere around 8 to 9, you're now pushing 90% on your herd immunity. So you need 90% of your citizens, of the residents in your community, to have immunity in order to prevent the virus from moving around your community. We're not near that. So you mentioned the numbers in Franklin. You're at 70%. Add a few percent, not a lot, for those who got infected but were not part of the vaccine count. So maybe you're at 75 or 78. So you're probably 15% or so shy of being at herd immunity. And it's almost impossible to achieve herd immunity in a community now with Delta, because 14% of the population in New Jersey is under 12. And so as a result of that, herd immunity is not going to really be accomplished in our state and in our communities until we start vaccinating the under 12-year-olds, hopefully next week.
Great. I've asked you this question before, and it's a little bit nerdy and technical, but I'm very interested in the answer. In India, as you know, it spiked and came down. I believe it did the same thing in France. Great Britain's a little more complicated, and I vacation sometimes in Jamaica, so I've been watching them, and it's spiking and coming down. But it's not like they've done great measures to mitigate it. Do you have an idea as to why it would do that? Is this something inherent in Delta?
Yeah, well, what's inherent in Delta, Mayor, is its transmissibility. It really is extraordinary to think about, watch, and as you just pointed out, we can watch it across the globe, what it does. We all really remember it was horrific in India. I mean, it was god awful as to how quickly it went up and how quickly it came down. It wasn't awful that it came down, but how quickly it went up and how universal the attack of the virus was. The virus is designed, I use the phrase, maybe a little morbid, but the virus is designed to hunt humans. And it hunts humans as long as there are enough humans around that are still susceptible to the virus. When you watch those spikes occur of a highly transmissible virus, it's blowing through the community and blowing in a way that it's attacking virtually everyone in the community, particularly in India at that point in time, that really was devoid of any natural immunity and of any vaccine immunity. So even though they didn't test everyone, we know that even with Delta, 20% of the population, 25% will get asymptomatic infection and develop some level of protection from that event. And if it hits 80% of the population in a township or in a state or in a country or in a community, and it does it quickly, as it did in India, the virus runs out of humans that it can hunt. And I think that's what we see when we see these horrific spikes, and then we watch it come down. What you've seen and what you've watched is a virus really just run through a community of susceptible individuals so quickly that it runs out of victims. It actually runs out of victims. And you know, that's a controversial issue, right? Because early in the pandemic, there were some Scandinavian countries who were sort of the mindset to just let nature take its course. We have that mindset to some degree in some of the states in this country. And, you know, I think that that's a policy, public health debate that we certainly, I guess, can have. As a frontline provider, I don't actually think the discussion takes into account the impact on our health system and our healthcare workers, but certainly it's been an ongoing debate throughout this pandemic.
Great. By the way, my back of the envelope calculation of RT, which is the current transmission rate, not the native transmission rate is R0, RT is the current transmission rate, is roughly 1 in Franklin. We're stuck at about 5 or 6 a day on a 7-day average.
Right.
Colin Powell. So when famous people get sick or don't get sick or do this or do that, everybody focuses on them. So Colin Powell was vaccinated and he died. So why should I get vaccinated?
Right. So, you know, being vaccinated doesn't mean you're necessarily protected. That's such an important point, and I hope there's lots of folks listening so that they can really understand the meaning of vaccination and protection and distinguish the two. So indeed, Colin Powell was vaccinated, but he was very likely not protected. And the reason that is because he had a condition. I'm not his doctor, so I know only what I read in the news, but he had a condition we're told is called multiple myeloma. Multiple myeloma is a form of a blood cancer that affects the cells in our body that produce antibodies. Antibodies are what we need to protect ourselves from infection. And people with multiple myeloma have a cancer of those cells, and they don't work right. And they don't produce antibodies in the right way to provide protection. And probably 60 or 70% of people with myeloma. In addition, he was on treatment for his myeloma with medications that poison the antibody producing cells because they're, in his circumstance, they were cancer cells. And so the way we treat cancer cells is we have to destroy them. And so he was taking a medicine that destroys the cancer cells he had, which happened to be antibody producing cells. So his body did not really have the wherewithal to make a response to the vaccine. So he should have been vaccinated. He was. He got both doses, which is great. It was planned, to my understanding and reading the news accounts, that he was going to get a third dose. But what's critically important to understand is that third dose probably wouldn't have protected him either, because his cells were poisoned. He had a cancer of the cells that would make a response to the vaccine. So what does that tell us? It tells us two things. Getting vaccinated, particularly if you're immune compromised, like Colin Powell, or someone with a transplant, or someone with a leukemia, doesn't mean you're necessarily protected. And your doctor, you got to talk to your doctor about that. And you have to say to them, I know I got vaccinated, but look what happened to Colin Powell. I understand he may not have been protected even though he got vaccinated. Is there something else I need to think about? The answers to that are yes, there are a couple. One is make sure everybody around you is vaccinated. Vaccinate the herd to protect those in the herd who can't be protected. Colin Powell couldn't be protected. It was incumbent on everybody that surrounded him that they were vaccinated and protected. And that's a really critical point, particularly within families or within circles of friends or within communities, when you have individuals who are susceptible because of their underlying health condition to not responding to the vaccine. So that's the first point. Vaccinate everyone around them. Circle the wagons. We're all here to help protect you, Uncle Colin or Uncle Ron, whoever it is. That's how you protect the individuals who may not respond. The second point, there is now an opportunity to use the monoclonal antibodies. And last time you had me on, Mayor, we talked a bit about monoclonal antibodies. There is now an opportunity to use monoclonal antibodies as what we call passive immunization. Passive immunization means you take an individual who cannot get a vaccine or who will not respond or doesn't respond to a vaccine, and you give them the immunity. Actually, that's what a monoclonal antibody is. It's the antibodies that you can't make. We can give it to you. So for Colin Powell, as an example, I have no idea whether he was getting it, but had he been my patient or had he seen me, I actually would have investigated that as an option to protect him. And we would give someone like Colin Powell or someone with leukemia who is not able to respond, and we can measure that, monoclonal antibodies on a monthly basis, as long as there is risk. You don't get it lifelong. If the numbers in Franklin Township drop to 0 over the next 3 weeks, you don't need monoclonal antibody because there's no disease to transmit. But as long as New Jersey is orange and until New Jersey is green, I'm giving patients who I see with that particular situation monthly infusions of monoclonal antibody to provide passive immunization. It's a really important point. It was approved probably about a month ago. What are we in? We're not quite November. Maybe a month, 4 or 5 weeks ago. I don't think there's enough press on that, and people aren't learning about that. So those are the two things to remember. Circle the wagons, make sure all your friends and family are vaccinated. Don't assume that your vaccine is protecting you if you have leukemia, myeloma, transplant. And number two, check with your doc. Maybe you should get passive immunization with monoclonal antibody.
Number three, blame the press whenever we can. You talked about one current treatment. The death rate has fortunately gone down, although long COVID is still a problem. But I assume that's due to some current treatments that we have. Can you outline those?
Yes, absolutely. And yeah, it's one of the good news stories. I'm always looking for a little bit of good news anywhere I can in COVID until it goes away. But yeah, our death rates have really dropped, dramatically. What the most important reason the death rate has dropped is vaccination. My constant theme. The reason the death rate is really dramatically lower is that we've done such a good job. And Mayor, you alluded to your vaccine rate in Franklin Township. If you look at New Jersey, in the group over 65 that's fully vaccinated, we're at like 87 or 88%, close to 90, fully vaccinated for over 65. That actually is the really good news story from the mortality or the death rate, because the majority of our deaths in the state were in the group over 65. And the biggest contributor to the decline in death rate is the fact that they were so vigorous about getting their vaccine in that age group. But we have had a number of really important advancements in the treatments. There are three in particular. The monoclonal antibodies we've already talked about, and they work very well early in the course of an infection to prevent the decline of someone who might be infected. There are antivirals. It's been around for a while now, remdesivir, but the data on remdesivir continues to look better and better. And it is pretty clear that when remdesivir is initiated early in people at risk, the mortality rates in those who get remdesivir, which is an antiviral medicine, only available intravenously, the mortality rates when you get that medicine early are substantially lower than if you don't get that medicine. And then third, most of the deaths that occur in COVID-19 disease are actually not related to the virus. It's not the virus that kills. It's the body's reaction to the virus. We call that the immune response. The immune response to the virus can sometimes be almost overzealous. And when that happens, it induces a syndrome, a condition. We call that condition the cytokine releasing syndrome or cytokine storm. It's that immunologic or overzealous immunologic response and the cytokine storm that actually kills people in COVID-19. We've gotten actually pretty good at managing that overzealous immune response. And we have a number of medicines that we now use in that setting to blunt the body's immune response to COVID. Sounds counterintuitive, right? You kind of want the immune response to destroy the virus. But on the other hand, if it goes a little haywire, you're at risk of serious illness and or death. So we've got to try to tamp it down a little bit. And the challenge as a clinician is the challenge of determining when's exactly the right time to implement these immunologic therapies to blunt that overzealous immune system, not harm the patient, blunt the response, and reduce the deaths. But we've gotten better at doing that. And we have a number of medicines that help us with that aspect of it.
I can remember my med school professor telling us at the beginning of immunology, the immune system is a two-edged sword.
Right. That's exactly correct.
So
Yeah, I
my
should
last-
mention, since you asked about treatment, Mayor, I should comment, I don't know if you were going to ask me, but many of you may have heard about the pill, the so-called Tamiflu, if you will, for COVID-19. It's a medication that was developed by Merck, a local New Jersey company, and I forget the name of the smaller startup company that they work with, but they developed this medicine, and it's almost certainly going to be approved shortly. It comes as 4 pills twice a day for 5 days. It'll be available for people to take early within the first 7 days of symptoms, preferably within the first 3 days of symptoms, to blunt the virus's effects and prevent the development of that vigorous immunologic response. It looks awfully good as a tool. And so we're all looking forward to having that available. Question of how quickly they're going to ramp it up. We're happy to see the numbers coming down. We might not need as much of it, but that drug is going to be available shortly, and it will add to our armamentarium.
So you say the numbers are coming down. What's your prediction for the winter?
Boy, I wish I knew. You know, I'm sort of not really into the prediction business, but you know, it's just so hard with this virus. Everything that we seem to try to predict always seems to go away. We all were hoping that I think it's all hope, right? So what am I hoping for? I'm hoping that we've deployed enough vaccine and enough boosters. I'm actually hoping that we've deployed enough boosters and we get enough of our young people vaccinated that there just aren't enough victims for the virus. So that's what I'm hoping for. What is that number? I don't know. We've talked about herd immunity. You need 90% to have some degree of immunity. You know, if you look at the Israeli epi curve, it's awfully suggestive that if we get 40 or 50% of our citizens boosted along with initial vaccines in our under 12-year-old members, you know, I would be optimistic the winter would be okay. But boy, Delta has certainly fooled me as well. And, you know, if it mutates enough and we get another variant that's able to avoid what we call immune surveillance, you know, who knows? We are looking at a new variant that some of you may have read about that's increasing in England. That's the place to watch at the moment. It's called AY 4.2. AY 4.2. We do not yet know, but we're concerned about it. We don't yet know whether it will overwhelm Delta. I actually hope it does not. But if it does, we may need to, you know, rethink what we're doing with our vaccines and what we're doing with our, you know, sort of public health measures. So watch England. That may be part of what you were alluding to as to why they've struggled a little bit. It seems like that variant's getting a foothold there.
So we are giving vaccines this weekend in Franklin at Winding Way. That's on Route 27 and off of Route 27 in the southern part of town. Go to the end of Winding Way. There's a park there. Rain or shine, they'll have a vehicle there so they can administer it even if it's raining. Please come out. It's at 1 o'clock on Saturday. It's when it starts, I think 1 to 4. Those are all my questions, Michael. You may have a few, and then our audience. And
Yeah,
our,
well,
our press.
I do have a few, but I'm going to let, and I was going to remind you to kind of talk about the clinic, but also there was a question about where you can get the vaccine. So Franklin has the one that the mayor mentioned, and then obviously you can get boosters at all the, you know, kind of typical places where people are getting them at their CVS's and other locations. So I got mine, and very, very easy. So let's go ahead and PJ and Bill, if you want to ask some questions of the mayor and Dr. Nahass, you have the floor. You're going to unmute.
Unmute. Am I
There you go.
unmuted?
You are.
Unmuted.
Yes,
now.
unmuted.
Yes,
Bill.
we hear you.
Raring to go.
Okay. I wasn't going to ask about the monoclonal antibodies, but since it has been introduced, I know of one case that was very personally something I was affected by. And this person was my brother. He was told in week 1, he had such a severe case of COVID to put his things in order. What saved him was proning, which was lying on his stomach. So his lungs were better positioned to receive oxygen, as well as the monoclonal antibodies and the remdesivir. He's fully recovered. He's home. And he's not going to get the vaccine because he feels his antibodies are strong enough right now. And there's going to be a clinic established within 20 minutes of his home for monoclonal antibodies. That sounds to me on the surface like an inarguable statement. However, what does that do to the concept of getting a vaccine? If one can think, such as he does, that if I get it, I'll just go get a dose of monoclonal antibodies and I'm fine. I don't need the vaccine.
So your question is
So my
that
question
advisable?
is,
Yeah.
what do you think, Dr. Nahass, of that concept?
Well, you almost indirectly answered the question by the story you told. So I would ask, is he willing to roll the dice again?
Apparently.
That he would be saved by proning monoclonal antibody and remdesivir. When I hear a story that someone was in the hospital and in order to survive, the clinicians, the doctors, the nurses ask that person to prone, that usually is an indication that the level of oxygen was so critically challenging that they were at great risk of potentially needing a ventilator or worse. So are you really willing to roll the dice again? We just passed, we're close to, the mayor may know the exact number, but in New Jersey, we're close to 30,000 deaths. I don't know, it's about 29,000 deaths in New Jersey. The majority of those deaths, not the majority, they're all COVID-related deaths. Those were right now in March and April, they weren't avoidable because we didn't have treatment. We didn't know what we were doing. Maybe they were avoidable if we had better public health measures. Now, every death that occurs is an avoidable death. Are we really willing to roll the dice as an individual and say, I'll take my chances with the monoclonal, remdesivir, molnupiravir, immunologic therapies, proning, and the doctor's intelligence? I appreciate the confidence he has in the healthcare system, but that makes almost no sense in the context of this virus, particularly if a variant occurs. Because remember, I mentioned this variant in England. If a variant occurs that can avoid immune surveillance, because those monoclonal antibodies only work for a limited number of variants. It doesn't work across the board. So, and the vaccine is like a no-brainer to me. I mean, obviously I'm in the business, but it's kind of like I gave the example. New Jersey has done so well on its death rates because we've gotten almost 90% of our citizens 65 and older vaccinated. That's the reason. And we've given 200 million people in the country the vaccine. I said this the last time, and I'll use it as an example. Our organization is a very large organization that sees infectious diseases, largest organization that sees it in New Jersey. We've seen now close to 20,000 people with COVID. We've lost maybe 4,000 or 5,000 people with COVID, 6,000 even, I think we're at. We have yet to have someone succumb to the vaccine. We've had nobody in an ICU in 26 hospitals, 130 facilities in the ICU on a vaccine. I don't know, the math is pretty obvious to me. It's pretty hard in my mind when I hear that story to say, yeah, it's not a bad idea, roll the dice and see what happens. The answer is get vaccinated. You don't need to roll the
Could have
dice.
easily gone the other way. I have a related question,
Exactly.
if I can tag on to you, PJ. Someone had asked about, if it made any sense, medically or logistically, to get an antibody test to gauge whether or not you think you might want to or need a booster.
You can't use the antibody test to gauge your level of immunity. The way it's useful, think of it as a response, yes or no. Remember, we talked about Cole and Powell. We talked about other patients. You can do the test in those compromised hosts, those compromised patients. Did you respond or not? That's the only question you can answer. I would have bet, I don't know this, but I would have bet that Colin Powell's test would have been, no, I didn't respond.
Right. Thank you. Sorry, PJ, go ahead.
Okay, well, thank you for answering my question. The concern being that it was a cavalier potential vaccine replacement. So thank you for answering that question. My original question had to do with us using the term booster and third shot almost interchangeably.
Yeah.
And it came to my attention, again, two people I know, one who had said, oh, I just got my third dosage. But make sure that when you get to your site, that you're very specific as to whether or not you want the booster or the third shot, because the booster is only a 50% dosage as opposed to the third shot, which is 100% dosage. I heard a similar story from someone else who went there and she was asked which she would prefer. I didn't know there was a difference. Is there a difference? Is the booster a 50% dosage of the vaccine and the third shot 100% dosage of the vaccine? And do you advise one over the other? I think I know the answer. Nonetheless, I'd like to hear it from Dr. Nahass.
Boy, can it get confusing? Isn't that been the story of
Absolutely.
this pandemic, right? The messaging around it continues to challenge us. Yeah, I'm not a big fan of the distinction because it is a bit confusing. But the technical reasons are that the booster for Moderna, if you will, which is someone who's a normal host, not Colin Powell. So you're immunologically normal. You get a booster for Moderna shot. It's the 50% dose because that's what they studied. For the Pfizer vaccine, it's not. It's the same dose. So in and of itself, it's almost confusing because the two companies offer different doses for the quote booster dose. The third shot is the implication of the third shot is that your first two shots weren't adequate to induce immunity. And so particularly in the immune compromised patients, getting another dose, you're giving them a third dose to prime their immune system. So that's kind of like the primary series for the immune compromised host. They're getting a third dose, not a boost. The boost is done to boost your immunity that you already have. If you're immune compromised, you may not have it. And so therefore you want to get a third shot. Very challenging nomenclature, very confusing, and asking most people to walk in, frankly, even most physicians, I will tell you, to explain the nuance of the difference is a challenge. I will tell you that, so I'll give you my own personal anecdote. I've received my third dose. Third dose, I said third dose. See there, I just did make a mistake. I received my booster. And I, because I am in the camp of mixing, I had 2 Pfizer doses and I did get a Moderna as my booster dose, but I got it before the booster dose at the half strength was available. So I got my booster dose as a full strength Moderna. You know,
It's
so
very confusing.
it is very confusing. Do I think there's any downside to getting a full dose as the booster dose? No. Do I think that there's a downside, and is there any evidence to suggest there's a downside of getting the half dose of the Moderna, if you will, as the booster dose? No. So I actually don't think it really matters. I think it's much ado about nothing, and it adds to the confusion, which is why I don't spend too much time talking about it, actually.
And Joe or Joanna Average walks in and asks for a booster and is presented with that question.
It's extraordinarily challenging. I think
Yes.
that they should just say, give me what you got,
Okay.
and they're okay.
Okay, I guess my last question has to do with the variants that you were talking about. It seems to be the science that the virus is attacking the vulnerable, who have the least strong host systems. On that level, if we have developed herd immunity, does the booster really make a difference? Or the third shot, or whatever we're calling it now?
It does. And it does for a couple of reasons. It's a great question, actually. The booster, I gotta think about what term I use. The booster induces more long-term memory. This is a basic vaccinology. Booster doses induce longer-term memory, so your body will remember longer. It boosts the immunity that's wearing off. We know that with all of the vaccines over time, the level of immunity drops. In boosting that level of immunity, it provides more security against the variants because it gives you a bigger cushion. So the higher or the more potent your immunity, the cushion against the variants is greater. And so as the virus mutates, it provides you more certainty that you're going to be protected. And in my mind, almost equally important, but that is not getting emphasized enough, that booster and that enhanced immunity dramatically reduces transmissibility. And we've all heard about breakthrough cases. They're real, they happen. Thankfully, they're not severe, but they are transmissible. And by getting that booster, we dramatically reduce transmissibility. And I alluded to earlier when the mayor was asking me some questions about the fire break. What that's doing is it's making a stronger fire break in our communities and in our families. And so it's really critical that we get those boosters to enhance the fire break.
And do you foresee that the booster is going to be the reality once a year?
Yeah, I do get asked that question a lot. At the moment, my answer is yes. It seems to me it's likely that we're going to need another one. And I will tell you that pharma is working on, a lot of the companies are working on a combined flu COVID shot for next year. So it wouldn't surprise me if next year, I don't think we're going to know till we get to next year, right? And so when we get to next year, it wouldn't be surprising to me if we're all lining up for our flu shots, we're actually going to be getting a COVID combined flu shot.
And pneumonia, I was told as well.
Well, the pneumonia shot is
rolled in.
That may be true. I haven't heard that. So I'm not aware that they're putting the pneumonia shot in with the COVID and the flu. And the reason I say that, I'd be a little bit surprised. It wouldn't surprise me totally, but it surprised me a little bit because pneumonia shots are not given annually. We give them once and done, or once in every 10 years. And so combining it with a shot that's needed annually doesn't actually make that much sense to me. But I wouldn't be surprised if somebody's looking at that, but it doesn't actually fit with the way we use those shots.
Right.
Okay.
So we have about 7 minutes left.
Yeah,
I
I asked way too many questions. Please, next person.
Bill, do you have any questions?
Just
We
a
have a
couple.
few minutes.
I just have a couple. Mayor,
Please.
if you know, are we done with the, would you call it the ancestral version, the original COVID-19? Are we done with that? Are we just now doing Delta in Franklin Township? Do you know?
The last thing I saw put out by our local health department, which is our county health department, is it looked like it was all Delta. I mean, maybe there was a slim other, but it was roughly 99% Delta. Is that what you've seen, Dr. Nahass?
Yeah, it's all Delta in the United States, all Delta in New Jersey.
Okay.
Watch for AY42.
That was my next question for Dr. Nahass. Has that arrived in the United States yet, or is it still just in the UK?
Nope, it's here. Keep watching what the mayor is alluding to. It's actually an important illustration. I look at that every time it comes out. Watch that small sliver that he's alluding to. Watch if it grows. I'm hoping it doesn't, but that's where we're all paying attention to it.
So the county's already tracking AY 4.2?
No, the county tracks it as other.
Oh, okay. Are there others then?
Others.
There's others. There are over 5,000 variants of COVID-19 that have been identified.
Terrific. So we won't know for a while yet until A14, if and when A14 kind of breaks from the herd, so to speak.
I hope it doesn't happen.
There was a variant, and Dr. Nahass, correct me if I making a wrong assumption here. There was a variant out of Colombia that was hitting in Miami, and it looked like it was going to be bad, and Delta beat it out. It's almost, I was almost rooting for Delta. And it's so infectious that it might stomp out other variants, but Certainly
exactly
Delta
correct.
is.
That's the one you mentioned last time we were together. That was making
Mu.
me nervous. So that
It was
didn't play
it
out.
was named Mu. In New Jersey, we got to about 4.2%, and Delta just snuffed it out. I was pleased to see that happen.
Yeah.
So what is that Colombian variant rate in terms of, I don't know,
R?
strength to the AY4 variant? Do you know? Does anybody know?
Well, the Columbia variant can avoid immune surveillance, and it's actually, it appears to be a little bit more aggressive, which is hard to believe, but it's not more transmissible. So what we learned with that experience is that transmissibility trumps immune surveillance, at least to some degree, and trumps lethality.
And how
Don't know
transmiss-
enough yet about the AY 4.2 yet to answer your question.
Okay, so you don't know enough about the transmissibility of AY4.
We don't know enough about the transmissibility, the lethality, or its ability to avoid immune surveillance. Those are the three characteristics that are watched to understand what it might do.
Okay. All right. Thank you.
Thanks, Bill. Thanks, PJ. And I just wanted to, I think we covered pretty much everything. There's a couple of small things, which was someone had a question about whether you can kind of have too many vaccines. So if there's, or you know, in terms of how close together, or should just, you know, space them out because people are getting, you know, shingles vaccines, flu vaccine, COVID vaccine. Any thoughts on that?
The immune system is a wonderful body part, is my concept. I don't think they can't give, I can't take enough vaccines as far as I'm concerned. The more vaccines I can take, the more I'll take. So the answer is, I'm saying it a little bit just smiling, because it really is, the immune system is extraordinary in its capacity and its repertoire. Take your shingles vaccine, take your pneumonia vaccine, take your hepatitis, take your tetanus shot, take whatever you can get. I take anything I can get.
So, but maybe what about getting multiple vaccines in the same visit?
Yeah, you know, originally when the COVID vaccine came out, we were telling people to separate the flu vaccine from the COVID vaccine by 2 weeks, because we weren't so clear as to what the expectations might be. But now that we have a really pretty good understanding in the expectations, it's perfectly fine to go ahead and take your flu vaccine and your COVID vaccine together. Might you end up with a more serious reaction? Maybe, but maybe you won't. And I've talked with a lot of folks who've done both together. Some people felt like their reaction was more severe. Was that really because they got two, or was it really just that there was more severe from one of them? And others breezed through both of them.
Right.
And so
right.
it's a unique issue to the individual. There's no reason you can't take both together.
Yeah. So we have a couple minutes. I'll throw one more at you. Or one is how often are you seeing reactions like inflammation of the lymph nodes with vaccine shots?
Yeah, that happens somewhat regularly, and that's created some problems for women in particular with their mammograms, because they get the shot in the arm, and that can cause some lymph glands underneath the armpit in particular, which can create challenges in getting a mammogram. But that goes away, you know, in a short order. And so I think you just need to be prepared that that's a reaction that can happen.
Yeah, and it seems to be, from what I read, more in Moderna than Pfizer. But I had Pfizer and I had the booster, and I had that swelling for on the arm where I got the Pfizer. I had the flu in the other arm, but that lasted about 3 days and then went away.
Right.
No issues with that. Quick question on if and when the children's booster the children's booster or the children's shot rather, for 5 to 11, that'll be likely given out in their medical home through pediatricians. Is it any more firm knowledge on how that's going to roll out if and when it's?
My understanding is what you said. It's going to be deployed in the pediatricians' offices. I think that's a great plan. I'm sure there will be some public health effort to make it available within communities. I'm not familiar with those rollout plans. Maybe the mayor has some sense of whether the county has any plan for the children. I think most of it's going to be done in the pediatricians' offices.
Okay, awesome. Well, we've used our full hour and we have recorded this. It'll be available both on Facebook, on the township's page, and I also made a recording in case they want to put it up on their website. And so I just want to thank you, Dr. Nahass, thank our friends from the Franklin Reporter, And Mr. Mayor, thank you. And if you want to sign us off.
Sure, Michael. First of all, thank you. Michael's always there when I call him to help with this. I'm going to share the screen here. Let's see if I can not mess it up.
And we got our Nixle today just a few minutes ago. 3 cases, no deaths. So that's
Can you see that every Monday, Wednesday, and Friday except holidays? Is that what's showing?
yeah, we can see it. It's
So from 4 to 7:30 PM, Pfizer and Moderna at the Somerset County Senior Wellness Center at 876 East Main Street in Bridgewater. If you want to get your shots.
Yep.
Plus, again, Winding Ridge Road, Saturday, Winding Way, not Winding Ridge Road, Winding Way, Saturday from 1 to 4. And it's at the end of Winding Way. There's a park, and that's where they'll be. Thank you, Dr. Nahass. Thank you, Franklin Reporter. Thank you, Michael. And as I always say, be well, Franklin. Good night.
Thanks.
take care, folks.